It's me, Jen, again, and today's video is an interview with a thyroid RFA provider in Atlanta, Georgia. We'll meet Dr. Steve Bomeli coming up. Earlier this year, I was invited to Baltimore, Maryland, specifically Johns Hopkins, where I attended an RFA physician cadaver training. While there, I got to meet lots of really interesting people in the RFA world. Today, we're catching up with one of those doctors to hear how it's going at his practice in Atlanta, Georgia. Let's get to know Dr. Steve Bomeli. How did you feel that training helped you? What was the most helpful thing you learned at that training?
Well, like anything, it's nice to talk to people who have done it before and kind of pioneered the procedure in the country. And it's good to just bounce ideas off them and see what got them into it, see how the results have been, because most of the literature is currently from Korean sources, but it's always good to have a little bit of data from here in the States as well. But we are up and running now, and it's going great, and definitely learned a lot on the procedures and the logistics, and so far so good. I was probably about 75 to 90% mind made up before I went there, and that kind of tipped me over the edge. Thinking about it the last year or so, and that was really the straw that broke the camel's back in terms of saying now's the time to do it. Updates in the journals, and believe it or not, patients asking about it. That's the other reason you kind of hear about things sometimes. Never trained on it because it didn't exist when I did my training, at least in this country. Again, if you don't keep your eyes and ears open, you're going to be behind the times. So word of mouth is key.
That's kind of how RFA seems to be spreading right now with patients, is that they're hearing about it and then they're looking for it. Or you said you had some requests from patients before you even started doing this. So are you having a lot of requests for this at your clinic?
Oh yeah, absolutely. Anytime you can say, well, there's an alternative to surgery, people's eyes perk up. An endocrine gland like the thyroid, people's biggest concern is generally, well, I have to take a thyroid medicine for the rest of my life if you take out half of it. And a couple of years ago, that was really the only option. Medical management to shrink thyroid nodules has been done for decades, and really doesn't work all that well. So it's nice to finally have another option that works, obviously, and better yet, doesn't require a trip to the operating room. Let's see, we've got 5 cases down, and again, so far so good. All good results. Done a toxic nodule as well, and just got the blood work back. I think 3 or 4 days ago. 1 month out, and normal thyroid function, no methimazole needed. That patient was actually on my surgery schedule, I think before we had the equipment to do the RFA, and I guess I must have mentioned it to her in passing, or she heard about it. Got a phone call the week before the operation was scheduled, and she says, would this be an option for me? And I said, absolutely. If you're willing to do it, we'll take you off the OR schedule and do this instead. And she's thrilled because she doesn't have to take a medicine and didn't have to go under general anesthetic. No scar on her neck, and no thyroid or anti-thyroid medication for her.
I can't tell you how often we see patients in our group who are scheduled for surgery, and they're still hoping that there's some alternative available. It's very common. We see a lot of patients who they say, my surgery's scheduled for a week or a month from now. Do you think I should look into this? And we always say, well, I mean, definitely you can reschedule the surgery if you need to, but you can't get your thyroid back once it's gone.
It's funny, I tell people that all the time as well. They ask, well, should I do the total thyroid or should I just do the lobe? And I kind of tell them, well, there's absolutely no way to put the thyroid back in after it's been removed. Personal preference, I'd rather have a second operation than remove a body part in its entirety. Unless you absolutely need to have that done. I haven't done any massive ones yet. I mean, I don't know what the exact classification for massive would be, but I think about 4.5 to 5 is the largest ones I've done.
That's a decent size. Mine was not much larger than that, and that's big enough that you are noticing it visibly and feeling it. And those patients are very excited when they get relief from those symptoms. So, have you been able to follow up with that patient yet on any reduction in size?
So we're looking at about 70 for the first 1% reduction at about a month.
Wow.
That was a little bit smaller one. I want to say it was maybe about 3 centimeters.
Yeah.
But again, obviously, kind of oriented in a place where you could see it.
Yeah.
And she just had a great result.
Tell me about the popping experience. Have any of your patients had that happen during their procedures?
Every single one.
Yeah.
I try and brief them about it, but of course, they always have a little bit of sedation on board, so they're not too worried at that point. But again, the popping, I guess, alarmed me a little bit more than it did them the first time. You kind of feel that, and again, obviously, that's a normal thing. I think it helps to have them relaxed. Again, I guess I feel it more in the handpiece potentially than they do through the neck. I think local anesthetic also makes a big difference. I'm pretty liberal with the amount of local use. So I think that helps them immensely. So, again, they probably don't feel anything more than just a little pressure or something like that, because it really doesn't affect them.
The popping is really kind of a novelty, that we talk about a lot in the group. With patients think it's funny or odd, but not really scary. In fact, I remember one of the pops that I experienced was like, whoa, what was that? But it wasn't like scary or frightening. Something I've heard a lot of doctors say is that they kind of celebrate the popping, like, this is a good thing, this means that it's working. So, yay. You're right about about feeling it in the probe. I really did not realize that you would feel the popping in the probe until I actually got to ablate some chicken myself. I was like noticing it in my hand. I was like, I feel the popping. That's crazy. I didn't realize that would happen for you as well as the provider. I ablated some chicken in Baltimore. And I also got to do some at Dr. Lefferts' office in Dallas. And it was so neat to be able to kind of be on your side of the table and see what it's like for you doing the procedure. I have to just tell you, my hat's off to you guys that do this procedure. Having the hand-eye coordination, holding the probe, holding the ultrasound.
I guess you kind of just take it for granted after you've kind of learned that skill, how to orient the needle in the ultrasound field. And it's not easy because the beam of the ultrasound is only about the width of a credit card. And lining up a 25 gauge needle is not the easiest thing to do. I would find that it's a little bit easier with the RF probe just because it's larger. It's a bigger target to see rather than a standard 25 gauge needle or a 27 for a fine needle aspirate. But if you know how to do a fine needle aspirate, it's essentially the same skill set to transition to the RF.
Now that I've actually had a chance to do it on chicken, I'm very impressed with the abilities of all of you that do this procedure, and I'm very grateful for those of you who are willing to do it for patients who desperately want it and need it to save their thyroid.
Like anything, once you get it, the more people hear about it, and just got the first online review glowing about the RF procedure, and again, that's where these patients come from. The internet has been my biggest referral source for several years now. So the more and more people have it done, the more word gets out, and again, that keeps people informed. The alcohol injections for cysts again has been somewhat limited by the availability of the alcohol. Sotradecol is another solution that's been used as well. Especially with the interventional radiology colleagues. So I've experience with both of those. And again, that's a great treatment for a cyst. Again, the reductions are pretty darn amazing. With just a single treatment. Again, the nice part about that one is it takes 5 minutes to do. Here in the office, again, I don't even use sedation for those, unless someone requests it. Again, it's literally just another glorified biopsy, except you aspirate the cyst and then inject it again with the sclerosing agent. A great option there to obviously reduce the compressive symptoms, reduce the cosmetic lump at the location of the thyroid without needing to, put somebody to sleep or put a scar on their neck. Well, I think the biggest thing, for patients is just to keep an open mind to it. Again, I think surgery is often thought of as a, kind of a quick fix or an easy solution. But the reality is it never comes without risk. So, you always have to be informed. And obviously, the risk of pretty much anything done in the office is far less than, a trip to the operating room. Negative occurrences are quite rare, but again, the risk isn't zero. There's not a week that goes by where I don't hear somebody saying, oh, I had a friend who had their thyroid removed, or a family member, or something along those lines. And ever since then, they've struggled getting the right dosage, and they have to not only have T4 but supplement with T3. I'm not an endocrinologist, so I don't see that primarily, but again, I kind of hear about it in passing. Nobody likes that.
Not to say that surgery isn't a necessary thing. For a lot of people it is, but for the times when it can be avoided, it's a wonderful thing to have an alternative. So thank you for doing this.
If you don't have to take a medicine, don't have to have things checked, well, you're doing better.